The following PowerPoint discusses systemic and CNS changes during pregnancy for Chapter 48 in Humans and Wind Neurological Surgery, 8th edition. And the authors are Sarah Burga and Nastaran Fuyuzi. Dr. Burga is at the Department of Obstetrics and Gynecology as professor and chair at Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo. And Dr. Nastaran Fuyuzi is a reproductive endocrinologist and infertility specialist with a focus on medical genetics for Kindbody in San Francisco. This chapter introduces a 4-part series focused on the pregnant neurosurgical patient. Subsequent chapters deal with the management of anesthesia and oncologic and vascular disorders. The present chapter reviews systemic and neuroendocrine changes during pregnancy that are relevant to neurosurgeons who encounter the pregnant patient needing neurosurgical evaluation and potential treatment. The outline of the presentation is shown here. We will first review systemic physiology, including hematologic, cardiovascular, pulmonary, renal, gastrointestinal, metabolic, and musculoskeletal consequences of normal pregnancy, and then review the neuroendocrinology of pregnancy, including changes in function of the anterior pituitary, posterior pituitary, the potential consequences of pre-existing pituitary tumors and pituitary dysfunction on pregnancy. It is critical to remember that nearly every maternal organ system is altered by pregnancy. The impact of pregnancy on the endocrine and neuroendocrine systems are profound and begin with implantation and the production of the hormone human chorionic gonadotropin, abbreviated HCG, which is made by the placental trophoblast. The impact of pregnancy on many organ systems is gradual and increases progressively throughout gestation. However, some are more abrupt. And while most changes are thought to be hormonally mediated, some organ systems are also affected by the enlarging uterus or secondarily by the vascular and physiologic increase in maternal blood volume. It is critically important for the neurosurgeon to recognize and understand the systemic changes that are gradual and subtle across gestation, the immediate and profound changes that occur intrapartum and postpartum, the physiologic changes of pregnancy that alter physical, laboratory, and imaging examinations that would otherwise be misinterpreted as abnormal, and the physical forces that the gravid uterus exerts on the maternal musculoskeletal system. The systemic and CNS changes that occur during pregnancy are shown below. As you can see in the first column, these are the systems that we will review. The hematologic system shows an increase in blood volume, plasma volume, and RBC mass that leads to a proportionate decrease in hematocrit. The cardiovascular system shows an increase in heart rate, cardiac output, a decrease in diastolic blood pressure that is particularly dramatic during the first trimester, and then a decrease in peripheral vascular resistance that reflects the growth of the low-resistant placental vascular bed. And then the pulmonary system shows a decrease in vascular resistance, an increase in tidal volume and respiratory rate, but a decrease in respiratory reserve. The renal system is characterized by an increase in GFR, a decrease in serum creatinine, an increase in renal blood flow, and a decrease in serum osmolality. The GI system experiences an increase in gastric emptying time due to the effects of smooth muscle relaxation mediated by progesterone, therefore a corresponding decrease in intestinal motility, gallbladder motility, and an increase in gallbladder volume. There are profound changes on metabolism that begin in the first trimester and accrue across the entire pregnancy. with an increase in weight, an immediate increase in basal metabolic rate, an increase in insulin action during the first trimester that gradually becomes a resistance to insulin during the second and third trimesters, predisposing to gestational diabetes. And then throughout pregnancy, there is a gradual increase in free and total cortisol, which helps to engineer some of the metabolic changes described. The musculoskeletal system shows ligamental laxity under the influence of several hormones, in particular relaxin, a compensatory lumbar lordosis as the rectus muscle has to relax to accommodate the growing gravid uterus, and then a corresponding shift in the center of gravity causing low back pain, and there is also an increase in carpal tunnel syndrome. Certain changes deserve emphasis. In regard to the hematologic system, there is a tendency towards hypercoagulable state that ensues in preparation for hemostasis following delivery. Pregnant and postpartum women are predisposed to venous thrombosis beginning in the first trimester, and this lasts postpartum for up to 12 weeks. Factors 8, 9, and 10 in fibrinogen levels increase by about 50%, whereas fibrinolytic activity, antithrombin, and protein S decrease. Endogenous anticoagulants such as antithrombin and protein S decrease, thus rendering the pregnant and immediately postpartum woman into a hypercoagulable state and at risk for venous thromboembolism. Platelet count decreases during normal pregnancy, and the diagnosis of thrombocytopenia in pregnancy is made when there are less than 10,000 platelets per ml. In vitro tests of coagulation, such as APTT, PT, and TT, remain normal in the absence of anticoagulants or coagulopathy. Plasma volume increases throughout normal pregnancy and peaks in the third trimester. The increase in plasma volume is greater than the increase in red blood cell mass, which therefore decreases the total overall hemoglobin concentration, hematocrit, and red blood cell count. There is no change in mean corpuscular volume or hemoglobin concentration per RBC. So to review, there's an increase in systemic blood volume, an increase in plasma volume, an increase in red blood cell mass, and a decrease in hematocrit. It is important to review what happens to the cardiovascular system during pregnancy, and we will start with the physical examination. Because of profound changes in cardiovascular status during pregnancy, the cardiovascular examination may be misinterpreted as pathological. In particular, the pulse may be bounding or collapsing, reflecting peripheral vasodilation under the influence of progesterone and the enlarging placental and fetal mass. There may be an injection systolic murmur found over the precordium, and the murmur may be loud and audible, and there may be ectopic beats and peripheral edema, all of which are normal during pregnancy. There are compensatory changes in the EKG that reflect a change in the position of the heart secondary to the enlarging gravid uterus with a left axis shift of QRS. Also frequently noted are atrial and ventricular ectopics, small Q waves and inverted T waves in leads 3, and ST segment depression and T wave inversion in the inferior and lateral leads 1. During pregnancy, there are profound changes on the cardiovascular tree. Cardiac output increases by 20% by the 8th week of gestation and up to 40% thereafter, mainly due to increased stroke volume and to a lesser extent, increase in heart rate. The maximum cardiac output occurs around weeks 20 to 28 of gestation, which is the second trimester, and increased cardiac output reflects peripheral vasodilatation and reduced systemic vascular resistance, which in turn reflects the placental remodeling of the uterine vasculature and the invasion by the placental trophoblasts to facilitate oxygen and nutrient exchange across what essentially represents an arteriovenous malformation. Given these rather profound changes in the maternal vascular system due to an enlarging placenta and the low resistance vascular system thereof, it's not surprising that there is a decrease in blood pressure in the first and second trimesters, but then as the placenta ages, the vasculature becomes more rigid and resistant, and there is an increase in blood pressure and sometimes the development of what is known as preeclampsia, and occasionally, unfortunately, seizures, which are known as eclampsia. All of this is felt to reflect the change in the vascular resistance that accompanies the aging placenta in the third trimester. So to recap, with regard to intravascular volume, pregnancy causes a hypervolemic, hypoosmolar state with a 30 to 50% increase in extracellular volume and a 30 to 40% increase in plasma volume. The maternal blood volume increases overall by 45%, and this is what allows the maintenance of maternal and uteroplacental perfusion in a low resistance state. In the late third trimester, plasma volume increases by more than 50 to 60%, but because the RBC mass increases less, the overall result is a decreased plasma osmolality. The increase in plasma volume combined with the decreased systemic vascular resistance thereby result in arterial underfilling unique to pregnancy. We recommend positioning the pregnant woman in a way that you might not otherwise do for surgery and actually even during repose. So in the supine position, the pregnant gravid uterus compresses the inferior vena cava and reduces venous return and therefore may decrease stroke volume and cardiac output. Turning from the lateral to a supine position may result in a 25% reduction in cardiac output. Pregnant women, particularly those in the third trimester, should therefore be positioned in the left or right lateral position to actually offload the gravid uterus to the side. And if the expectant mother must be kept on her back for a craniotomy or such, the pelvis should be rotated to drop the uterus off the inferior vena cava to optimize cardiac output and uteroplacental blood flow to minimize fetal compromise. As everyone recognizes, cardiovascular system during labor is challenged. The cardiac output increases an additional 15% during the first stage of labor, and which is defined primarily by dilating cervix. And then during the second stage of labor, which is the descent of the head or presenting fetal body part, there is a further increase. Uterine contractions autotransfuse about 300 to 500 ml per contraction, and pain and anxiety increase and elevate the heart rate and blood pressure. So during labor, there are rather dramatic challenges to the cardiovascular system, but these challenges are also present postpartum after delivery, because with the delivery of the fetus and the placenta, there's a dramatic increase in the afterload that increases venous return and stroke volume. It takes roughly 2 weeks to return to a prepartum state, and during this time, this can be very challenging, particularly for women with underlying structural cardiac defects. So careful monitoring of the postpartum woman is always recommended to look for development of pulmonary edema and other consequences that may ensue due to a cardiac inability to keep up with this volume. So to review, the changes in the cardiovascular tree during pregnancy are shown here. There is a dramatic increase in heart rate, particularly during labor. There's an increase in cardiac output, a decrease in diastolic blood pressure during the first and second trimesters, and a gradual and sometimes dramatic increase during the third trimester. And the changes primarily reflect a change in peripheral vascular resistance, which is a decrease in the beginning during the first and second trimesters, and a gradual or sometimes dramatic increase during the third trimester as the placenta ages. This slide reviews some of the common changes in the pulmonary system that occur during pregnancy, that obviously due to the demands of pregnancy, which are not proportionate to fetal mass. There is an increase in oxygen demand and an increase in basal metabolic rate, which lead then to a need for increased O2 consumption. This leads to hyperventilation with an increase in PO2 and a decrease in CO2 and a compensatory decrease in the serum bicarbonate. Thus, pregnancy is described as a mild, fully compensated respiratory alkalosis that is physiologic. Nonetheless, pregnant women may report breathlessness at rest or with talking without hypoxia, and this increases and is most common in the third trimester. Despite the increase in blood and stroke volume during pregnancy, pulmonary capillary wedge pressure and central venous pressure do not increase significantly. Pulmonary vascular resistance, like systemic vascular resistance, decreases slightly in the first trimester and significantly as pregnancy ensues. The serum colloid osmotic pressure is decreased, as is the osmotic pressure by 30%, increasing susceptibility to pulmonary edema. Pulmonary edema may be precipitated by either cardiac preload, such as the infusion of fluids or the delivery of the fetus and placenta, or by increased pulmonary capillary permeability, such as occurs in preeclampsia and eclampsia, or most of the time, all of these factors pertain. So to review, there are not only extraordinary demands placed on the pulmonary system during pregnancy, but also rather significant changes that could be misinterpreted. There is a decrease in vascular resistance, an increase in tidal volume, an increase in respiratory rate, and a decrease in respiratory reserve. Not surprisingly, pregnancy has a major impact on the renal system, with dilation of the renal, pelvic, and calyceal systems. Hydronephrosis therefore develops in over 80% of women, with right greater than left. And urinary stasis in the dilated collecting system predisposes pregnant women to asymptomatic bacteriuria and to pyelonephritis. During pregnancy, kidney stone risk increases because of the increase in GI absorption of calcium, which begins around 12 weeks. The effects of pregnancy on the renal system are briefly reviewed below. There is an increase in glomerular filtration rate, a decrease in serum creatinine level, an increase in renal blood flow, and a decrease in serum osmolality. Changes in the gastrointestinal system are shown below. Primarily, there is an increase in gastric emptying time due to smooth muscle relaxation under the influence of progesterone, and that leads to a decrease in intestinal motility, a decrease in gallbladder motility, and an increase in gallbladder volume. Pregnancy causes a diabetogenic state in the pregnant woman, and gestational diabetes occurs in 10% of pregnancy. Because of this, we have in place guidelines for screening for what is termed gestational diabetes. We know that basal metabolic rate increases dramatically across gestation, with a 4% increase in the first trimester. That's not proportionate to placental or fetal mass. And then by the third trimester, there is a dramatic 24% increase in metabolism that requires an extra 500 kilocalories per day. Part of the energy cost of gestation is offset by a reduction in physical activity, which is most profound during the first trimester as metabolic adaptations ensue. Some of the other changes in metabolism that accrue during pregnancy are shown here. There was an increase in weight, an increase in basal metabolic rate, an increase in insulin action in the first trimester, which leads to hypoglycemia if abundant fuel is not available, and a decrease in insulin action that is progressive in the second and third trimesters that can lead to gestational diabetes. And across pregnancy, there is an increase in both free and total cortisol, and this is actually part of how the metabolic changes of pregnancy are actually engineered. It should be obvious that pregnancy presents a challenge to the musculoskeletal system, both on the basis of anatomy and physiology. So there is an average gain of 25 to 35 pounds and a shift in the center of gravity due to the enlarging gravid uterus. This leads to a diastasis and relaxation of the abdominal wall to accommodate the growing gravid uterus. This is followed by compensatory lumbar lordosis and then strain on the axial skeleton, pelvic, abdominal, and spinal musculature to allow for this compensatory change. Multiple hormonal and biomechanical alterations ensue, partly under the influence of relaxin, which leads to laxity in the connective tissue. And basically, the anterior and longitudinal ligaments of the lumbar spine relax, and there is widening and an increased mobility of the sacroiliac joints and pubic symphysis to allow for descent of the fetus during delivery. The number one complaint, of course, is then frequent low back pain during pregnancy. So while low back pain is frequent, it is frequently also non-progressive. It doesn't necessarily mean that there's pathology. Carpal tunnel syndrome is common, but also generally non-progressive, and there's a tendency in the third trimester for Bell's palsy, and this is sometimes severe, but generally speaking, there's complete recovery. So to review, the adaptations made by the musculoskeletal system are shown below. There is an increase in ligament laxity that is hormonally mediated, a compensatory lumbar lordosis with often the chief complaint of low back pain, and an increase in carpal tunnel syndrome during pregnancy. We will now turn our attention to systemic and CNS changes during pregnancy that affect the neuroendocrinology of the pregnant woman. During pregnancy, the anterior pituitary gland increases by about 30% in weight and twofold in volume, with the highest values occurring immediately postpartum. The posterior pituitary gland becomes difficult to visualize as pregnancy progresses due to the increasing size of the anterior pituitary gland and overall shift in proportions. The increase in overall pituitary volume may impinge on the optic chiasm and cause bitemporal hemianopsia, and pseudotumor cerebri, benign intracranial hypertension, is more common in pregnancy. The following table summarizes changes in anterior pituitary function during pregnancy. And the first column shows what what the percent increase is in each cell type, what is the hormone that is made by that cell type, whether or not this increase is due to a change in cell number, and whether or not the placenta actually produces a similar hormone. So, for instance, for thyrotropes, there is about a 5% increase in thyrotropes. These are the anterior pituitary cells that make TSH. There is no change in cell number. And of note, the maternal production, the placental production of HCG actually stimulates the maternal thyroid to increase the production of T3 and T4. So TSH and HCG are somewhat similar enough to actually co-stimulate the maternal thyroid, and the maternal thyroid is the sole source of thyroxine for the developing fetus. So a very important mechanism is at play here. Lactotrophs increase by about 15 to 25%. These are the cells that make prolactin. There is an increase in cell number, and the decidua also makes prolactin. Somatomatotrophs actually increase by about 50%. These are the cells that make growth hormone, and these are important for stimulating all cell types, but particularly the breast. There's a decrease in cell number, and the placenta also makes a type of growth hormone called growth hormone 1, and we typically refer to the endogenous pituitary growth hormone as growth hormone 1. Corticotropes make ACTH. There's about a 10% increase in ACTH during pregnancy, but no change in cell number, and the placenta makes a rather profound amount of CRH that helps to engineer the entire cadence of pregnancy. Gonadotropes increase by about 20%. FSH and LH are made, but they decrease across time as they're no longer needed to stimulate the ovary across time. So initially, there is a corpus luteum that makes progesterone, and then eventually, during the first trimester, the placenta takes over the production of progesterone, and the corpus luteum is no longer needed. The placenta clearly makes a large amount of steroid, including estradiol and progesterone, and also other hormones. And these are under initially the influence of HCG, which is homolog to LH, but also other stimulatory factors as pregnancy progresses, because HCG then starts to decline. At term, the composition of the adenohypophysis is 60% lactotropes, and the increase persists during lactation. The increases in pituitary size render the pituitary susceptible to underperfusion and necrosis, and particularly so if there is a drop in blood pressure during or after delivery. So delivery is a vulnerable time for women and can result in postpartum pituitary apoplexy, which is termed Sheehan syndrome, and the presentation can be highly variable and depends on the extent and location of pituitary and stalk damage, and may initially not be evident, but may present later due to fibrosis. Only 1 to 5% of prolactin-secreting microadenomas expand during pregnancy, so a woman who has a microadenoma can be reassured. However, those who have a prolactin-secreting macroadenoma may experience an expansion, and this occurs in about 15 to 40% of women, and actually may require neurosurgical intervention. Pregnancy is a state of physiological hypercortisolism due to the placental production of CRH. The etiology of Cushing's disease and syndrome is much more likely to be adrenal during pregnancy and pituitary outside of pregnancy. But making a diagnosis of either type, but particularly pituitary Cushing's disease, is exceedingly difficult during pregnancy because of the overall enlargement of the pituitary gland during pregnancy, and because of the profound hypercortisolemia and hypercortisolism that results from placental production of CRH. During the first trimester, growth hormone of maternal origin increases, but then it falls as placental production increases. During the third trimester, growth hormone is exclusively of placental origin. Acromegaly is the second most common pituitary adenoma during pregnancy, and growth hormone pituitary adenomas can expand during pregnancy and cause neurological or visceral complications. Neuroimaging is particularly recommended for detection of macroadenomas. Autoimmune lymphocytic hypophysitis is particularly challenging during pregnancy. It is a rare but important cause of hypopituitarism during pregnancy and the peripartum. And MRI is the best way to differentiate autoimmune hypophysitis from non-functioning pituitary adenomas, as shown here. So the MRI features are shown below, but it's important to differentiate what autoimmune hypophysitis is and how it differs from pituitary silent adenomas. So first of all, the affected population is typically third trimester of pregnancy or postpartum, whereas the latter is primarily postmenopausal women and men over age 50. The origin of the hypophysitis is autoimmune. This, in fact, may represent a phenomenon known as fetal microchimerism and maternal versus fetal host versus graft disease. Whereas in pituitary adenomas, we are dealing with a polyclonal expansion of a pituitary sort of cell that is non-secreting. Common symptoms in autoimmune hypophysitis are mass effects, whereas silent pituitary adenomas really may be entirely silent. Symptoms are associated with mass size in pituitary adenomas, but are out of proportion in autoimmune hypophysitis. The hormone deficiencies that accompany autoimmune hypophysitis are primarily ACTH and TSH, whereas pituitary silent adenomas, it's primarily LH, FSH, and then growth hormone. The treatment for autoimmune hypophysitis is medical, whereas the treatment for pituitary adenoma may well be surgical. And some other features, as we noted, can be distinguished on MRI. So gland enlargement in autoimmune hypophysitis is symmetrical, whereas in silent pituitary adenomas, the non-functioning type is usually an asymmetric enlargement, and the distinction can be seen on MRI. The pituitary stalk in autoimmune hypophysitis is centrally located and enlarged, whereas in pituitary adenomas that are non-functioning, the stalk may well be deviated without thickening. The posterior pituitary signal is none in MRIs for autoimmune hypophysitis, but may be present in pituitary adenomas. The cellular floor is normal in autoimmune hypophysitis, but is eroded most commonly in non-functioning pituitary adenomas. And enhancement is diffuse and homogeneous in autoimmune hypophysitis, and there's no enhancement of the mass in non-functioning pituitary adenomas. Finally, we review changes in the posterior pituitary function during pregnancy. There is a fourfold increase in vasopressin secretion, and in fact, transient diabetes insipidus may result from increased vasopressinase, the enzyme, or vasopressin resistance during preeclampsia. Postpartum pituitary apoplexy, Sheehan syndrome, actually may involve the stalk, and may compromise the posterior pituitary and may present, indeed, as diabetes insipidus. And when this happens, it's rather dramatic. This is Dr. Sarah Berge. It has been my pleasure to review the systemic and CNS changes during pregnancy, with the focus being on what the neurosurgeon needs to know. When in doubt, we recommend that you consult your high-risk obstetrician, otherwise known as a maternal fetal medicine specialist, for additional details, because we recognize that the changes that occur in maternal physiology during pregnancy are both dramatic and somewhat confusing, as they differ so dramatically from the non-pregnant state. And so we appreciate your attention to this important topic and look forward to collegial interactions for patients who present during pregnancy with neurosurgical conditions that require evaluation and potential treatment. Thank you so much.